Today I would like to discuss about RHD hemolytic disease of the newborn. Anti-RHD IgG antibodies are the prime cause of severe HDN. This results from isoimmunization of RHD negative mothers, which may be due to a RHD positive pregnancy or transfusion of Rh positive blood. Factors influencing the production of Rh antibodies. 1. Size of feto-maternal hemorrhage. 2. Parity. 3. Effect of ABO incompatibility between mother and the fetus. 4. Zygosity of father. 5. History of blood transfusion. 6. Medical termination of pregnancy or miscarriage. 1. Size of feto-maternal hemorrhage. The amounts of fetal red cells which cross the placenta into maternal circulation in the third trimester of pregnancy are usually small and insufficient to cause antibody production. In addition, elevated steroid levels and other factors associated with pregnancy may suppress the mother's primary response. Usually the first Rh-incompatible fetus is unaffected. At delivery, a transplacental hemorrhage is not uncommon. The amount of fetal blood entering the maternal circulation varies from less than 1 milliliter to 10 milliliters or more. The RHD positive fetal red cells stimulate the production of anti-RHD in about 5 to 9% of these RHD negative mothers. The antibody appears in the mother's blood within 6 months of delivery, and 7 to 12% of the mothers become sensitized but do not have demonstrable levels of antibodies until they have secondary stimulus during a subsequent pregnancy. When pregnancy with a second RHD positive fetus occurs, the fetal red cells crossing the placenta from about the 24th week of gestation either stimulate the sensitized mother to produce antibody or increase the existing antibody to higher titer. The anti-RHD formed is IgG, thus it is capable of crossing the placenta into fetal circulation, where it combines with RHD positive red cells, leading to their destruction. 2. Parity. Parity is defined as the number of times that she has given birth to a fetus with a gestational age of 24 weeks or more, regardless of whether the child was born alive or was stillborn. Incidence of sensitization. First pregnancy, no HDN. Second pregnancy, chance of HDN is 150. Third pregnancy, chance of HDN is 129. Fourth pregnancy, chance of HDN is 120. Fifth pregnancy, chance of HDN is 19. Average of chance of HDN is 133. From this table, about 70% cases are confronted with HDN in second or third pregnancy. 3. Effect of ABO incompatibility between mother and the fetus. ABO incompatibility between mother and fetus provides some protection to the fetus from Rh-HDN. It is believed that the existing maternal ABO alloantibodies destroy the RHD positive fetal red cells immediately as they enter the maternal circulation before they can sensitize the mother. Once the mother becomes immunized to Rh antigen, this protective effect is lost. 4. Zygosity of father. If the father is heterozygous for the implicated antigen, there is 50% chance of the child being affected by Rh-HDN. If the father is homozygous, there is no chance of the child being affected by Rh-HDN. 5. History of blood transfusion. RHD negative mother who has been immunized by RHD positive blood transfusion has a risk of delivering a baby with Rh-HDN even in the first pregnancy. The risk of immunization is greater with RHD positive blood transfusion than with Rh positive pregnancy in a woman, since the antigen load is much greater in transfusion. 6. Medical termination of pregnancy or miscarriage can also immunize the Rh negative mother.